Okay.
Okay, welcome everyone. My name is Beth Boudreau. I'm responsible for professional education at ClaroNav, the Navident division. And we have a great program for you right now, presented by Dr. George Mandelaris and moderated by Dr. Bradley DeGroot. The program tonight is Dynamic Navigation and All on 4, transitioning the natural dentition to full arch implants rehabilitation. We want this to be a very interactive experience, so we encourage you to please type in any questions that you have, and our moderator, Dr. DeGroot, will be keeping his eye on that and getting back to you with your answers. We also have time built in at the end of the program, about 10 minutes or so, to address your questions at that time. Also at the end of the program, I'll be giving you the instructions to get your CE documents. This program is good for one CE credit. Okay, so without further ado, I'd like to introduce our moderator. Dr. Bradley DeGroot earned his dental degrees at Marquette University in Milwaukee, Wisconsin, and then completed a 3-year periodontal residency at the University of Texas Health Center in San Antonio. Dr. DeGroot has authored articles in peer-reviewed journals and textbook chapters on the topics of digital dentistry, implant placement protocols, surgically facilitated orthodontic therapy, dynamically guided implant surgery, and interdisciplinary treatment planning. Dr. DeGroot has lectured nationally and internationally on topics of periodontology and implant surgery. Dr. DeGroot, the screen is all yours.
Well, thank you very much. Thank you for having us here tonight, and thanks to everyone who's joining us from here and from abroad, and just excited to be here and be a part of this. So you all know, I will be monitoring the chat throughout the presentation tonight. And so if you have a question, go ahead and type it in. You should see that on the lower center of your screen. I will try to answer those directly to you if I can. Otherwise, at the end of his presentation, I'll re-ask George those questions out loud so that he can address those. So if you do have a question, please type it in. I'll try to make sure I don't overlook anything. And thank you very much for that. So with that, George Mandelaris graduated with his dental degree from University of Michigan and then did his periodontal training at Louisville. He's authored numerous articles, chapters. He's participated in a number of world workshops. He was the co-chair at the American Academy of Periodontology's consensus workshop for the use of 3D imaging in dentistry and implantology. He's just been an innovator in our field and a great mentor and teacher, and so very excited to turn the floor over to him. So George, good luck.
Brad. Thanks, Brad, and thanks Beth for letting me use my high school picture for this webinar. With the COVID crisis going on, we've not been practicing here in Illinois for about well over a month, and I used to have a conditioned hairstyle, but now it's pretty much out of control. All right, so I want to just kind of bring to you, my journey and our evolution in using dynamic navigation, kind of what spurred it to really, why did we incorporate it into the practice, and then end with a couple cases where we've been able to transition the natural dentition using dynamic navigation surgery for fully guided implant placement and immediate load protocols. So I want to start with this slide because it's the software system inherent in the Navident navigation system that we're talking about today. And this really falls under the umbrella of computer-aided implantology. And under that umbrella, we have two arms. We have static guidance, which we've all kind of grown up with. These are the stereolithographic medical models, originally the pilot guides, and then moving over to the fully guided systems, beginning with the SAFE system, and then into obviously Nobel Guide, Biomet Navigator, and so on and so forth. But basically those guides control you in all three planes of space, as well as the vertical position and perhaps even rotational timing. Navigation now gives us a leap forward, because what we're able to do is to have real-time verification and validation of positional accuracy. And that was really critical for me. I'm going to show you the case that really kind of spurred me to say, you know what, we need to go beyond this. We need to go to the next level, because I need to have information as it's happening for the patient on the spot. And so one of the things I like to put up about this slide is not the razzle dazzle of the software, or, hey, look, I can put an immediate implant in at number 8 and do it, you know, with zero discrepancies or positional errors. But rather, the imaging gives us an opportunity to sit down as an interdisciplinary team and think about the patient from a craniofacial standpoint first, and then work our way in from the face coming down into the teeth. When we treatment plan, we go from the teeth back out to the face. That's facially generated treatment planning. But when we look at this scan here, one of the things I think is important is to make a decision on what type of material are we going to use to fill the gap between the facial alveolus and the outer aspect of the implant. We're trying to create an organ system here. We're trying to create a vascularized functional matrix that's going to sustain mechanotransduction for decades of this patient's life. Is it bioos? Is it mineralized bone? Is it autogenous bone? Perhaps it's a tissue engineering molecule like BMP2. But these are questions I think we need to pose, because we're oversimplifying guided surgery, and we're oversimplifying complex problems that have real implications on patients. And this is at the core of what imaging is all about. It allows us to scratch the surface and ask questions deeper and more significant than two-dimensional information. So, you know, how do we avoid digital intoxication? Because that's what's going on today. Well, the only way to really do it is what you see in the middle. You know, we start with an examination process, and how we may provide therapy is perhaps going to change as time goes on. We may be able to do it with robotics. We may be able to do it more exacting. We may be able to do it more minimally invasive. But what doesn't change is the importance and the necessity for an accurate diagnosis. That doesn't change no matter what type of treatment is going to be executed. So the need to establish an accurate diagnosis then basically is first and foremost, and then having the technology to think outside the box and create treatment plans based on that patient's needs and concerns will never change. How we might manage a diagnosis based on the technology that's available certainly will cause us to change. But those two things in the middle are key, and that's really the core of imaging. So when we pose the question, are we accurate with static guidance? One of the things I like to talk about is this paper that I was involved in with my former partner, Alan Rosenfeld, many years ago. You know, back in the day, we were considered pioneers with guided surgery, and we were trying to bring Biomet 3i's Navigator system, which was competing with the Nobel Guide, to provide some literature and to basically bring some data so that it had an evidence-based approach for market share. And so we were involved in this multi-center study that was spearheaded by Tiziano Testori, and we treated. There were 25 patients in this study, 8 centers in Europe. The 2 centers in the U.S. were our practice and Scott Gann's. And with all of us, we placed 117 implants. This was medical grade CT scanning. This was using Simplant. And then we basically placed implants using bone, mucosal, or tooth-borne tooth mucosal guides that were Biomet Navigator proprietary instrumentation. And so after the surgery was done, the patients would go back to the imaging center, have another scan, and then we would send that data to Tiziano, and Tiziano would basically merge the data sets, and a third party, a blinded person, would basically look at, you know, how good were we with our outcomes? What's our entry point deviations, our angle discrepancies? And what he found was, you know, a pretty reasonable outcome. In fact, these numbers are pretty accurate with what you found in the literature and with other systems. So it validated that system. What really made this study different is that Tiziano looked at something called the center of mass. And so what you see here is the implants in position where we had them planned in green, and where they ended up in red. And so you see a distinct difference between the center of mass and where all these implants were really off to some degree. But basically it went back to the positioning of the guide, because in almost all of the cases, the guide was not in the position from which it was constructed or from which it was developed. And so there was this discrepancy between the plan and then the positioning of that guide, which caused a movement. And that was actually the case in almost every case we did. In 18 of our 25 cases, had deviations of over a millimeter. Only 8, in less than 8 cases of 8 of 25 cases had less than a millimeter, and only one case, and that's what I really want to impress upon you, in only one case was there coincidence between what was planned and what actually occurred. And you're talking about, Tiziano Testori, you're talking about Scott Gans. I mean, some of the most world famous people involved in guided surgery. And these are the numbers that that occurred. So it led us to basically say, we should have a 2 millimeter safety zone, and then in immediate loading cases, go with the provisional restoration, because there's, in terms of getting passivity of fit, it's going to be pretty difficult to do. So to compensate for inaccuracies, go through provisionalization and then final restorations. And so when we talk about dynamic navigation, not only do we want to be precise, we want to hit the target, but we also want to be able to hit the bullseye. And we want to hit the bullseye not just once, but over and over and over again. Okay, so we want to be precise and we want to be accurate over and over again. So again, getting back to imaging and kind of giving us an opportunity to think outside the box, think creatively, think at a bigger level. When you look at this case, number one, you should be thinking, well, that's a compensated upper incisor. That's patient probably from a craniofacial standpoint has a class 2 division 2 skeletal malocclusion, and these teeth have compensated as a result of that. The incisor angulation is not in the same trajectory as the native bone, so that tooth is going to require lingual root torque if we're going to get it in the right position and to overcome the compensations. This is a skeletal class 3 patient, and each one of them are going to present with inherent, differences in terms of skeletal bone, in terms of bone around the teeth, and then potentially, this is going to impact mechanotransduction and loading forces distributed in the arches accordingly. And so with a situation like this, that's not a bad choice. An immediate implant there, you're going to have to manage the gap to a degree. But a situation like this, perhaps that type of an implant isn't the best situation, isn't the best implant size to choose. Well, I wasn't thinking that way, several years ago. This is a case I'm going to show you down the road. It's an immediate implant with the implant alveolus gap grafted with BioOS collagen, and it looks good on an X-ray. And this is my case that was done for this patient. We're going to use an angle correction, but the implant is really pretty much right where I had it planned. Didn't need to do much for the implant alveolus gap, and I thought everything would be, pretty slick, and I was able to do it minimally invasive. Well, after I started loading the implant, after the restorative doctor started loading the implant, this is what happened to the facial bone. And I wish I kind of had this article when I was thinking about these cases, because one of the things that this paper talks about, sorry about that. One of the things that this paper talks about, are the issues that we as clinicians impose on our patients. So when you think about the facial bone changes and you think about maybe, cases that are not as aesthetic as we would like them to be, some of these papers show us that in general, oftentimes the implant is in what's called two buccal of an implant position. There's some movement of it. And that leads to early crestal bone remodeling, crestal bone loss, exposure of the implant surface. And these things can be triggers for peri-implant disease. So again, going back to the core issues of the patient, think of the patient when you walk into the clinic and see them and just look at their face. Think about what their face is telling you. Do they have flat cheekbones? Do they have you know, a retrognathic, you know, mandible? And how are these bony craniofacial structures going to impact our implant positions, and how are they going to impact mechanotransduction long term? You know, remember that case in the middle, I was able to put the implant in very accurately, but the problem is I wasn't remembering that that bone on the facial is bundle bone, and bundle bone is tooth specific bone. So once the tooth is gone, that bone is gone. And this is what you see now long term, is that bundle bone, that tooth specific bone being gone, and then the loading of that prosthesis on that phenotype, you know, has probably caused, you know, has some contributing factor to the limitation in facial bone volume that we noticed there. This was an older patient. This was not somebody who's going to go through the Ford osteotomy, but that's getting a little too deep. What I want to show you is this tipping point. And this was a patient that, you know, we as periodontists and oral surgeons are going to have to be dealing with over and over again. This was a patient who had multiple implants placed in the anterior maxilla, and you know, they were done well many years ago, many decades ago, but you know, he's suffering from peri-implant disease now, and you know, would like a long-term strategy. Well, the long-term strategy is obviously going to start with this, because there's no way we're gonna you know, resurrect the bone around those implants, nor are they really in favorable positions. So we're going to remove the implants, as well as number 6, we're going to just place platelet-rich fibrin in the socket, close the area, and put them in a long-term provisional. I'm now going to set them up for rather complex guided bone regeneration. And so we're going to go ahead and do a titanium reinforced membranes perforated. This is the Isfahan Urban kind of technique. And we're going to be doing horizontal and vertical ridge augmentation using autogenous bone from the ramus, particulated, and then also incorporating tissue engineering with BMP2 and cancellous allograft. We're going to create the geometric form that we want, maintain the space, stabilize membranes, close the area with passive wound closure, and then put his provisional on, you know, removing the vertical nature of the teeth to account for some swelling that will happen. And now, you know, he's gone through a pretty significant surgery, and he's going to have to wait 9 months before we go to the next step. Well, now we're at 9 months. And we have a provisional made. We set up the teeth in the right position. Everything is prosthetically generated. I send all the data to the laboratory, and now I'm sitting down with my restorative doctor, and we're going to go ahead and create a plan. And I had taped this, so I want to show this to you, okay? Because this is what actually happened. Okay. So we're in a webinar, and we've got the position of the teeth planned out here. And I'm going to scoot you through this, but basically what you see is the segmentation that's being done. And now the lab is going ahead and positioning the implants. In this case, we're going to use the Biomet Navigator system. I was pretty comfortable and familiar with it. And I've got the implants placed in what I would say are relatively good positions. They're coming through the cingulum. Everything looks like it's going to be nicely screw retained. Space appropriation is well positioned, you know, and everything looks pretty good. And I want to call your attention to number 10. I think it looks in a decent position. Things look pretty good here. So I don't know, we spend 30 minutes or so at lunch going over this case together. Everything looks good. Yep, go ahead. Let's order the guide. And you know, I can't wait for the surgery. So the surgery occurs. This is over 9 months now. I'm going to go ahead and open the flaps and take the membranes out, take the tacks out. Bone graft healing looks beautiful. Everything looks great. We go ahead and put that guide on. Now, you know, I'm coming from a practice where we've done a lot of this stuff. And in fact, we published a book on guided surgery. So I'm feeling pretty good. I got inspection windows. That's seated really well. And, you know, things are looking pretty smooth. And in fact, I had the lab make a conventional vacuform guide for me so that I can, you know, put direction indicators in and show the doctor I'm putting these implants in exactly where you want these implants to be. And I'm documenting this case. Now the patient, Philip, has gone through, I don't know, maybe 9 months, a year or so of all this treatment, waiting to get to this moment when I'm about ready to put the implants in. And I go ahead and do that to the best of my abilities using the most sophisticated technology at the time, which was totally guided implant surgery. I go ahead and do a little contour grafting, put a new provisional on, take a photo to, you know, show how great that looks, go ahead and close the area. And that's how we how he was about to leave. Unfortunately, my assistant came in and said, "Hey, I think you need to look at this X-ray." And as I was mentioning to you earlier, I was kind of hoping I would have had this article, because basically what this article showed is that there are tolerances within our sleeves, not just in with where the implant is going, or the guide is going, where your drill is going, but also the tolerance between the master cylinders and the guiding cylinders. And so there's a little bit of slop with some of these systems, and you really don't have any representation of tooth position in space unless you make a conventional guide like I've made there. But most of the time, that's probably not being done. So the implants are in. My assistant comes to get me and says, "I think you need to look at the implant at number 10. And I say, "Well, okay, well, that's obvious because you're coming around a curve. There's no way that looks like that. I've gone through all this planning. How could that possibly look like that when that wasn't anywhere near what the plan, indicated a month ago when we planned this together?" And she goes ahead and takes another X-ray, because I'm sure she's coming around a curve and that's not right. And that's what I've got. So we're at a crossroads now. Do I depend on an orthodontist to move the distal of that cuspid back through the sinus? Do I leave it? The patient's already paid for the surgery, and just kind of hope that it works. Or do I take it out, which is exactly what I did. We're doing significant procedures on patients. This is a redo. This guy's not coming back and doing all this surgery all over again. So we absolutely positively have to get it right. And we have to be using technology that allows us transparency on the spot when we're doing these technologies when we're doing these surgeries, to make sure that we are hitting the bullseye over and over again. Think about the cost of revision surgery. How much has he already spent? What's this boo-boo basically done to my reputation and the trust, not just with my patient, but the relationship I have with him and the referring dentist. They're putting their trust and confidence in me that I can do a great job for them, and I can't give them back something where this implant is in the root of the tooth when that's not even where it was planned. So with dynamic surgical navigation, it really, for me and Brad, has become kind of the next level and the next leap forward. So when we talk about navigation surgery, we're really talking about computer-aided implantology, where a computer is going to register a jaw from a cone beam data set and then provide on-screen real-time guidance to the surgery who operates freehand. So it's freehand surgery, but you're looking at a computer and you have opportunities to definitively ensure that what you're seeing is accurate, and you can have instant feedback of what is occurring. And so you're in total control. These are common in medical surgery. This is an endoscopy procedure using electromagnetic navigation, and then the type that we use, which is optical navigation through these tracking systems, which you see here in these cameras. What's interesting about surgical navigation is that it's been around a long time. Dates back all the way to 1908 when stereotaxy was invented. Now, most of it's been used for neurosurgery purposes and so forth, and it really hasn't been involved in dentistry, until the early 2000s or so, when RoboDent basically came and DentX came on the circuit. But these were large, bulky units that just at the time really didn't have a place for private practice. But now in 2013 and beyond, with Navident and with some of the other systems on the market, this is the next level in guided surgery. And just recently, we published a paper on trace registration technology, which takes the nuance of having a fiduciary out of the equation, which I think simplifies workflows and makes life even simpler. When you may ask, well, how long does it take to get proficient? If I buy the system, am I going to be good after 10 cases, 1 case, 20 cases? What's it take? Well, everybody's different. And all I can tell you is what I can relate to what's in the literature. And so if you're a GI surgeon, you're probably looking at 60 simulator trainings to get good doing, endoscopy type procedures, doing colonoscopies. If you're a neurosurgeon, you're talking about, 100 to 500 cases of endovascular neurosurgery using, navigation type technology until you start to see a reduction in the incidence of complications. This is a great book. It's called The Checklist Manifesto. And so I think it's important to read because shit's going to hit the fan at some way, somehow, at some point. And you have to be able to not depend on the technology, but make sure that you have a biologic compass and a periodontal conscience. And what I mean by that is we have great technology, but we also need to kind of know how to do things the old-fashioned way and get out of trouble if something goes awry, and it will with any level of technology that you use. So this is a great read. When we talk about navigation surgery, no matter what system that we're talking about, we're looking at 5 components: a laptop to run the system, a drill tag, a jaw tag, a micron tracker, which is where the optically positioned sensor is, and then a mobile cart that maintains it. In the US, you're looking at Navident and XNav. The inlet system, to my knowledge, at this point is still not FDA cleared. It's in Canada. With navigation surgery, we have this coordinate mapping chain that ensures that the cone beam data set and the drill tip registration is and remains accurate throughout the surgery. So we're going to register the drill axis and our tips, our osteotomy tips to the system. We will calibrate the unit, and then the system ends up tracking as we are operating. There are some error potentials, and the error potentials are these, where there could be inaccurate registration that's not observed by the operator. There's tolerance of parts. So if you're using a drill extender, let's say, you're going to have a little slop in that, and that will cause some tolerance that you have to be mindful of. Changes in the anatomy between the time that you take in the scan and the time that you operate, and then any optical tracking noise. Basically, by and large, if you don't recognize potential errors early, they are going to compound and magnify exponentially. The beauty of the Navident system is you have the opportunity to do accuracy checks. So at every step along the way, I can check and make sure that what I'm doing is indeed accurate before I go to the next step. And Brad and I have created a checklist of something that you can kind of look at and follow, which is kind of like a cookbook method of surgery. So where I do a lot of this is in the anterior zone, because it's got to be right. I'm going for the cingulum screw retained prostheses all the time, and I want to have the most accurate information at my fingertips to make sure that I've got the implant in the best position that I'm able to provide for the patient in my interdisciplinary team. So this patient, this is Jackie, and we're going to take out 8 and 9. They're hopeless teeth. Facial bone is intact. Earlier on, we were using a little different system with these thermoplastic stents, and you'll notice that I'm basically registering the drill tip to the system. So I have a jaw tag, I have a drill tag, and I do not need to look at the markings of the drill any longer because the system is registering the tip, and it's going to be tracking the tip as I do the surgery. So as I look at the computer screen, it's tracking the tip. And I'll show you what you'll see on the screen in a minute. Here are the 2 implants in position with Ostel smart pegs showing the trajectory of those implants. And look at what a paradigm shift this is. I mean, my eyes are not looking at the patient. My back is upright and I'm looking at that computer screen. My assistant is double checking, but I tell you, you've got to have a transfer of trust in the technology, just like we did with guided surgery. We have to have a transfer of trust in this technology, and you can't shortchange any of the steps or you're going to get in trouble. But if you don't, and you're fastidious about the technology and learning it and really making sure that every step is well adhered to, it's remarkable. And so I'm looking at this computer screen like a GPS, and it's tracking and telling me exactly where I am. And look at these entry point deviations and angle discrepancies. I mean, I don't need to buy a $200,000 robot to do much better than that. That's pretty darn good. I could have done a little better, maybe the angle discrepancy on number 9, but for the most part, those are pretty good numbers. And this is what's even better. Not only having a beautiful emergence profile of these provisional restorations done by Chris Ching, a wonderful dentist in Glenview, but well-positioned implants in not just the buccolingual and the mesial distal, but most importantly, the vertical position, which allows the correct representation of the tooth form with enough running room and screw-retained access so we don't get ourselves involved with cement sepsis. And then here are the final restorations. This was published by Brad and myself, and then our our mentor, really, who I think is on the Zoom call here, and with Luigi. He's really, I think, probably the world expert in this technology, and I owe a lot to him for getting me to where we're at. But we wrote this article. It was kind of an overview. It's a good paper and compendium. Unfortunately, as time has it, a lot of the technology is outdated now because we're not using the thermoplast stents, and things have simplified. But that's what's so wonderful about Navident, is this company is continuing to innovate and continuing to push forward to make our lives easier, more predictable, more accurate as clinicians. This is a complicated case. It's a medically complex individual who has a hopeless terminal lower dentition. And so even though I've got the technology, and you're not noticing much with these other than these are kind of hopeless teeth, we have to start with the end in mind, no matter where we're headed. It goes back to that first slide of exam and therapy, but it's diagnosis and treatment planning, and it must be facially generated, and it must be prosthetically directed. So we're going to start with a new denture setup for her, and then I'm going to plan backwards. I'm not going to get into this case too much because I'm going to show you how we would do it today, which is how you would do it, but we would still work with new prosthetics, new dentures to set this patient up in the right phonetic, aesthetic, and functional position. So minimally invasive surgery, I'm going to go ahead and remove the teeth. I'm going to go ahead and lower the bone in this area. So I've done my ostectomy, and I'm putting the scanning appliance in place. And now today we were going to use something called a bone anchor template. Before we were using these little mini implants, which are not FDA approved, and then we would attach a fiduciary, take the patient, get an image, bring them back, put the jaw tag on it. It was just kind of a mess because it didn't allow you to plan, outside of the clinic, where you can kind of think and just have collaboration and then come in and execute. And today we've got better workflow patterns, and these are continuing to be evolved and improved even as we speak. So this is an example of a bone anchor template. We use little salvin pins to kind of hold this in place. And that's an example of an edentulous model and how we might do that. And so here's my patient. I've lowered the bone. This is when we were using the mini implant, but we don't do that any longer. Instead, today we would use something like this, where we go ahead and we would attach the jaw tag to the mandible. In the maxilla, I'm going to use a head tracker, although I can use a jaw tag as well. The head trackers are designed specifically to account for movement, and they are highly, highly stable, and I'll show you the newest editions of that. That was an example of the jaw tag, circa 2018 or so. But this is the position of the implants and the immediate load process, which is going to now go forward. But I want to call your attention to the extent of the surgery. While it's not minimally invasive, it is less invasive than had I put on a huge surgical guide and done this with totally guided surgery. So, reducing the risk for vessel damage and just, smaller scale surgery. And this patient took, a couple of Tylenol, and that was really about it. She did exceptionally well. Still want to have a prosthesis to confirm that those implants are right where they need to be. And then the immediate load prosthesis there and there. And here's the patient in the end. And you'll notice the nice position of the implants and a really happy patient. And without, doing a rather complex surgery with exacting and precision technology today, allowing me to do it in as minimally invasive a context as I think I could have done it. And then also being assured that the implants are exactly where Dr. Stein, Avi Stein, the prosthetist, were exactly where he needed them to be. And that's our, that's our commitment to our doctors that we work with. We're doing our best to try to get them exactly what they expect from us, so that we can make their lives easier and more predictable. And then the wonderful thing about the technology also is that you can re-image this patient, and then you can really be humbled, because this is a software called EvaluNav, which basically allows you to register the preoperative plan with the postoperative outcome and see exactly how accurate you were. And so while this shows that, I look like I'm pretty close, I'm actually about 1 millimeter in terms of an entry point deviation. And my angle discrepancy is around 3.5 degrees. So pretty good, but not perfect. We're working hard, we're getting better and better. Now, I don't want to just sit here and kind of show and tell and show you my cases. I interest into this field and try to elevate the profession through the literature and through research. And I want to show you this this paper that we published in 2019, largely with at Luigi's through Luigi's efforts. So this was a patient population of 231 patients. Luigi did all the surgeries. And basically what we found in using the older thermoplast stent system is that the entry point deviations in using this technology were 0.71 millimeters. And look at the standard deviation. I mean, that's like nothing. And the angle discrepancies were, hovering around 2.5 millimeters. So that was our outcome, first publication in vivo data using this technology. And then the other thing that was interesting about this case is that when we compared doing the osteotomy site with navigation surgery and then placing the implant with navigation compared to doing the osteotomy site preparation with navigation and then putting the implant in freehand, you were better if you did the osteotomy site and you placed the implant with the technology. So even if you just use it to do the osteotomy site, if you look at these numbers, you're going to be pretty good. You're better if you follow it all the way to completion. And what's even better is when you don't give up. Because when you don't give up, you get better. Luigi studied his first 50 implants, and he's really pretty good. He's better than what you're seeing with the computer guided, with totally guided implant outcomes. But when he compared his first 50 implants using the technology to the last 50 implants, you notice a marked improvement. Almost 100%. So we're getting better and better the more that we do. So taking things a little bit further, this is an edentulous mandible that we're going to use. Again, a scanning appliance here that's in place. And so this is something called point pairs registration. This was a bite appliance that we were using. We would image the patient at that point, and this is kind of what we would see. And again, this is called point pairs registration for an edentulous protocol. When we use the trace registration technology, which I'm going to get into in a minute, you'll notice that we no longer need these fiduciaries in the imaging, and the teeth become the fiduciaries themselves. This shows tracing at least 3 teeth. Generally, tracing 6 would be better, but your teeth become your fiduciary markers, which in the mandible, you still need a jaw tracker, but the optical sensor is basically reading the jaw tracker and then the tracer tool. So this is the dimple fiduciary points in the tray, which a patient would be scanned. Today, and this is what it would look like. And today we might use something like this with these metal fiduciaries in there in the edentulous protocol. So these are evolving and they're improving as time goes on. Just this last month, we had the good fortune of having some more of our work published in the International Journal of Periodontics and Restorative Dentistry. Again, these were patients primarily of Luigi, and he did the surgeries. He looked at 136 of his cases in 59 patients. And using this novel trace registration technology, which I'm going to talk a little bit about, we found very, very, incredible data points, so outcomes measures. So when you look at the coronal position of the implants, the mean coronal deviation from the plan was around 0.6 millimeters with low standard deviations. When you look at the angle discrepancies, you're hovering around 2.5 millimeters, maybe upwards as much as 6 degrees, but that still can be easily compensated prosthetically. Again, when we looked at, if you traced 3 to 4 teeth compared to if you traced 5 to 6 teeth, one of the things that we found is that you generally were a little bit more accurate if you had more teeth that were traced as a part and registered as to secure the plan with. And then this is the new example of the head tracker that's also part of the publication. Some of the cases you'll see are a little bit older and it's not exactly the same head tracker, but this one has been modified after a lot of feedback, and it's very, very stable. So this is what's out there in the literature. Mike Block initially was kind of leading the way with XNav, and you see his numbers, which are really quite impressive. Again, that system has a fiduciary, it's a fiduciary dependent system. Our numbers, again, from Luigi, our first paper where we were using fiduciaries and a thermoplast stent, very comparable to what Dr. Block had published in the Journal of Oral Surgery. And now our publications with trace registration technology, which simplifies the workflow. This is a paper that will be coming out in PRD, and then another one looking more so at the accuracy of placing implants with this technology in the pterygoid region. So pterygoid implants, obviously with vital structures being rather critical in that area, you need to be on point, and having this type of technology, as long as it's secured, it's very accurate, or it's as accurate as you are, let's say. When you compare some of this to static guidance with the systematic reviews, again, you have, relatively good angle discrepancies and entry point deviations, but I just would call your attention to the standard deviations, because they're really quite large. And if you look at the Van Asch study, where where a standard deviation could be up to 25 degrees and, and 6 millimeters from an entry point deviation, you have to wonder, why am I even using a guide? Our numbers are much more tighter, and our tolerances are much tighter. Our standard deviations are much tighter. And so it's become very clear to me that this is really kind of the next emerging standard of care for guided surgery. Performing accuracy checks, which is essentially a way of assuring congruency between what you actually see on the computer and what you actually see in the mouth. So if I put my drill tip on tooth number 26 there, and it shows that I'm in the lingual of that tooth on the computer screen, or that I'm in the pulp, well, then I need to start over again, because somewhere, somehow, something happened where this isn't quite right. But if it shows that I'm exactly, if the computer screen shows me exactly what I see clinically in real time, then I've got congruency, and I'm going to go ahead and start my osteotomy site preparation. What you'll notice here is this is a jaw tracker that's actually affixed to the teeth using some simple composite resin. Today we have other opportunities as well. This is a jaw tracker that basically can be attached using some polyvinyl siloxane. It's really pretty simple, and it works very, very well. So you don't have to get involved in kind of messing with composite around the teeth. You do have to have at least 2 to 3 teeth for this to be secure, though. So in my 4 years of doing this, I think that from my perspective, the advantages of navigation surgery, I can only speak for Brad and I, is that it allows me to do real-time verification and validation of positional accuracy. That's really what it's all about. Real-time information. It's dynamic. So I can change on the fly. So in other words, if I want to put in a 4.6 millimeter implant, but I had originally planned for a 3.8, I can make that change on the fly, and I'm not locked into a particular guide that doesn't give me that flexibility. That's a big advantage. It does allow me to perform minimally invasive surgery, and I can do it much quicker. If I've got all of my ducks in a row, then I can do the surgery the next day. I don't have to wait for a guide to be made. That may take a week or so. It reduces the cost to patient. Perhaps that's an operator, decision. That's up to you to kind of, does this influence your care skill and judgment and your knowledge? Does that, is that something you're going to impose on the patient or not? But I can tell you it does reduce surgical time. Once you get really good at this stuff, it really doesn't take a lot of time to get things registered, set up. And what's also great about it is just the excitement from your staff for them to know that you're using the same type of technology that neurosurgeons use to remove tumors. It's not manufacturer dependent, so I can use whatever implant system I want. And there's a camera that's recording the technology and the action, so it provides really a level of transparency and unprecedented medical legal documentation, which is unlike anything we've ever had, in the profession. And again, the more you do it, the more confidence you're going to get. And like I said, it's versatile. Now there is a cost to the system. So, just like anything, any type of technology, whether it be cone beam or digital, surface scanner, there's these yearly fees and ongoing software upgrades and licensure costs, but these are important because this allows the company to kind of continue making improvements in their product, and that really feeds back to us and allowing us to do better patient care. This is a company that's all about integrity and all about advancing things humanity and for the right reasons. And that's why I'm working with them. Their edentulous workflows are not perfected yet. I'm going to show you 2 cases at the end, but they're getting there, and we're working hard to try to improve protocols. It's not integrated with pre-surgical CAD/CAM prosthetic development yet, and it's sometimes difficult to take intraoperative periapicals. If you have severely mobile and periodontally involved teeth, those are not reliable to use for trace registration, so we're going to have to use other opportunities. And then a lot of metal artifact, not a good idea to use trace registration in that situation, but what you can do is you can basically provide a surface scan of that jaw, and you can merge the data sets and then use that STL file to do the tracing. You can't control rotational timing, and there is a bigger learning curve. But let's look at where it matters. This is a 7-year-old, and I'm not putting implants in a 7-year-old, but I want to just show you kind of like, we think of it in terms of, just operating on a patient in that particular day. But when you think about the journey that the patient has been on for that particular moment that you're operating on them, there's a lot on your shoulders. There's a lot of trust and confidence there, because this is supposed to be something that you do once for somebody, and then it lasts for a long period of time. And if we're part of the problem because the implants aren't in the right position, or they're too buccal, or they're too this, or they're too that, and we haven't planned them properly, and we haven't used the right technology to execute them at the best of our abilities, then that's really on us. So this patient has become 13 years old now, and luckily she was in the hands of a wonderful prosthetist who told her that this is an acceptable orthodontic position. We went ahead and, unfortunately, she was referred to another orthodontist, but we got her in a good axial inclination of the teeth, got her in a good occlusion. And this is basically kind of, now she's meeting me. She's now 22 years of age. She's finished college. She's got these bonded provisionals, and she wants teeth now. So think about this, 22 years old from age 7. This has been a 15-year journey to get to this particular moment that I'm about to operate on her. And so for me, when it absolutely positively has to be right, I'm going to use the most state-of-the-art technology. And so what we'll do is we'll get the imaging, we'll go ahead and do a digital impression in the diagnostic setup, and then it will merge the 2 data sets. I'll map the prosthetically directed teeth with virtual teeth. I'll remove those, then plan the implants in 3D, making sure everything's in the right position based on the prosthetically directed position that the prosthetist has indicated. In her case, we're going to use a head tracker. So this is an example of the new head tracker. And then trace registration, as you see here. So all these little points are what has been traced. The blue and the dots are basically where I had indicated I was going to start, and the yellow is where I actually did start. But trace registration is essentially a volumetric mesh that gets generated using an algorithm through a tracer tool, which essentially is like a stylus pen that has this tracker attached to it. And the dental surfaces register to them, and then it renders the patient anatomy. So with this much green on the screen, I'm pretty confident that what's been registered has been accurate. But what you'll notice is that there were only 3 points that were started. And I really would have done 6 today if I had known then what I know now. First thing we do, minor flap surgery. I'm going to put the dental gingival complex in the right position for the biologic width. And we're going to go ahead and do a minor aesthetic crown enhancement. I'll also go ahead and do cortical perforations because I'm going to do some contour grafting with that. And then we're going to do receptor site preparation so that I have the bone topography in the right spot. I know exactly where to put the implants in a vertical position. And that's probably the most critical thing. So here what you see is dental, gingival, and peri-implant complex positioning so that we get the right tooth display and we get the right position of the implant in the vertical plane. Cortical perforations to encourage angiogenesis. And then here you see me operating on my patient. That she's wearing a head tracker. I'm using 2 hands to kind of stabilize the implant, the drill tracker, and then this is the computer screen that I'm looking at. You see the target view there on the left, and I'm basically following the system is following the tip of the drill to the final vertical position. I'm able to look at angle discrepancies and axial deviations. And there the implant in position in the clinic, and then one-stage implant surgery, EvaluNav showing, you know, relatively impressive entry point deviations. Angle discrepancy off a little bit on number 7, but really quite good at number 10. And then one of my first cases was basically a replica of what Alan and I did, you know, 10 or 15 years ago. And that, you know, we needed to trust the technology. And so what we did was we were going to use navigation surgery, but I'm also going to have a stereolithographic guide, because if something goes wrong with the navigation technology, I want to be able to fall back onto what I know best. And so what I had done here is I had a stereolithographic surgical guide made. I'm going ahead and doing the case with navigation surgery, but I'm also going to have this as a fallback. So the fallback is going to be navigation, the technology is going to be navigation surgery with vacuform suck down. I'm going to go ahead and do my osteotomy site preparation. And if everything that I've done with navigation surgery is right, the guide should fall right over the center of that direction indicator, and you notice that it absolutely does. So that osteotomy site was created with navigation, and I'm using the stereolithographic guide to make sure that that's correct. Because I can't control rotational timing, and this custom healing abutment was made with the hex kept in it, I was off a little bit, and I had to modify that. But that's the end of the surgery. There's the position of the implant. You know, great angle discrepancy and entry point deviation there, and then final restoration with Ken Milan case that really turned out quite nice for this individual. Opportunities for flapless surgery, again, kind of complex extraction socket grafting with BMP2, planning the case out there using a cingulum approach, and then just using a little cookie cutter approach, head tracker, tracing the teeth, and then positioning the implant in the right position, plenty of soft tissue. There's where we started, bone grafting, and then the implant in position. There's the cross-sectional view post-surgery, and then the provisional being put into place, you know, and then 2 weeks later with nice emergence profiles, and really a great result for this patient with a screw retaining restoration. You almost can't really tell which is the implant, which is the tooth. An immediate implant here gets a little bit more difficult because you're bouncing around a lot in the socket. There's validation and verification. This is the provisional in place, and then the EvaluNav. I'm going to kind of move through some of these because I want to get to the last case here, the immediate loading, which is what you came to see. So I want to show you Catherine. Kathy is somebody who was happy with her teeth. She has a debilitated dentition, but this is a case that is really quite perfect for this type of a scenario. So the first thing that we should do is a trial tooth setup. We want to set the posterior teeth. We want to duplicate that. We want to make a scanning appliance, and then we want to make an immediate denture for her. And then that immediate denture is then going to be converted to an immediate load prosthesis. But because these teeth, albeit periodontally compromised, are very stable, I can use them for trace registration as I use the technology and keep this somewhat minimally invasive. In her case, we decided to do bilateral sinus grafting at the same time as placing 4 anterior implants. And so what I'm going to do, and this is Kathy and this is her smile, is we're going to plan her case out. This is with the prosthetics kind of being removed and just the virtual teeth being left behind. And so we'll use a head tracker in her case. And so what I'm going to do is I'm going to trace register all anterior 6 teeth, and I'm going to make sure that that registration is accurate. How do I know that it's accurate? Because I'm going to take the tracer tool, and I'm now going to trace around each tooth and make sure that that stylus pen is exactly on the tooth on the computer screen with what I see clinically. And then I'll start and I'll calibrate my drill tip, and then I'm going to take my drill tip and I'm going to put it right on the palatal of number 6 and make sure that that's exactly accurate with what I see on the computer screen. I'll then go ahead and remove teeth numbers 7 and 8. I'm going to do another accuracy check around teeth numbers 6, 9, 10, and 11 and make sure that that drill tip on those teeth is exactly what I see on the computer screen. If it is, I'm going to go forward and go ahead and do my osteotomy site preparation and place my implant using dynamic navigation. The next step is I'm going to take out now number 10, and I'm going to go ahead and do my accuracy checks on the remaining teeth. I'll put the implant in at number 10. I'll then take out number 6 and do my accuracy checks at number 9 and number 11, which are remaining, and make sure that those are accurate. I'll do my osteotomy site preparation, put my implant in at number 6. I'll then take out number 11, do an accuracy check at number 9, make sure that that looks correct, and then do my osteotomy site and implant placement at number 11. So 2 tilted implants, 2 anterior implants in the pathway that I was kind of showing you. So there's the implants there. They're the trajectory of the implants. And then I'm going to make a duplicate. I'm going to have a duplicate denture made. I'm using angle corrections here, but I make sure that those are exactly where they should be, where they were with the plan. And I'm going to confirm that those are in a good position prosthetically. So there are the implants in position. We've got 4 implants in the anterior maxilla with angle corrections. And then I'm using a denture to make sure that that is, the angle corrections are correct. We do our sinus grafting, we pick up the prosthesis, and the lab technician is now converting that in the end. And you see there are the implants in position using the technology that we've talked about. And then the immediate occlusal load abutments, and then the prosthesis loaded in place with her occlusion checked. And there it is from the occlusal view. You'll notice most of them are kind of coming through the cingulum areas. And this is how Kathy started, and this is how how she left. And so for me, it's a defining moment because we're able to take a very complex surgery and really get it done very accurately and to an extent minimally invasive and transform her life. This is the power of what we do, as a profession, and using a team approach. We can transform people's lives, and she doesn't need to go to an implant super center to have this done. We can do this right here in our communities, using this novel technology. This is the post-op scan, and you'll notice that the implants are, really well situated in the available bone. Because I didn't have little mini pins put in, I wasn't able to kind of cross-reference the plan with the outcome and use the EvaluNav software. But I want to end by showing you one of my good friend Luigi's cases. And in this case, basically what he's going to do ahead of time is he's going to put in these little Salvin mini screws because he's not going to have the luxury like I did of having stable, although periodontally involved teeth to trace and then register and then perform accuracy checks as we selectively remove teeth and place implants while we use the technology. So if this was a lower case, we would use a bone anchor tag, as I showed you before. Here we're going to do a digital surface scan, and then we're going to go ahead and make a denture setup. This denture setup will be our scanning appliance, and we have little fiduciaries in there that you notice. This is the scanning appliance. This is the plan in place. These are the little mini implants, the little mini Salvin screws that were put in the upper jaw before the surgery occurred. And so we will be able to register these little mini, we'll do our accuracy checks with these mini implants. We can kind of cross-reference the two. And so here is the prosthetically directed plan. We've got the teeth in the right position, the dentures set up, facially generated. And there are the implants in position. This is the immediate load prosthesis against the lower denture. And unfortunately, with the COVID crisis happening, all over the world, Luigi didn't have a chance to do the lower arch just yet. But let's kind of look and see exactly what he did do. This is a little movie that he provided to me, and I want to thank him for that. And you can kind of watch and see, what he's going to do. He's going to place 2 pterygoid implants. Again, the implants are all been set up prosthetically directed. And so now we're going to go ahead and calibrate using these mini implants. He will trace and do our accuracy checks. So there's the accuracy check. You see the stylus pin is exactly on the Salvin screw, which is in the jaw. There's the planned implant position on the right pterygoid position, the right pterygoid implant. And now he's looking at the target view, and we're trying to look at that bullseye and making sure that we're exactly accurate. Now, if there's a question, he can pull that drill tip out. He can touch one of those little mini screws, and he can look at the computer screen and make sure that where his drill tip is exactly what he sees clinically. And if that's the case, then he'll proceed and finish the osteotomy site preparation. So what you'll notice as we're moving forward here is you can see the target view, which will come up on the left here. And that target view is showing us not only the entry point deviation on the top, so he's about 0.5 degrees from where we planned. He has 1.7 degrees or so, he's off angle, and he's got 9.5 millimeters to go to create the osteotomy site to complete the depth there. And so this is essentially what navigation surgery is affording us. Real-time verification and validation of positional accuracy. He's trying to, really thread the needle in the pterygoid areas and then get the implants in the ideal position in the maxilla. And you'll notice here, again, we're calibrating, taking things to completion and placing these 6 implants, in an edentulous model, and then moving towards the immediate load prosthesis. So thank you, Luigi, for providing that to me. As I think about future directions with this technology, we have expanded opportunities for navigation, not just with prepping teeth and shaping teeth, but we can incorporate haptic technology for improved control, probably facilitating the digital workflow process where we can merge soft tissue data with intraoral surface scan that's already here. Using cutting guides, perhaps. Some of the technology allows us to use piezo surgery and create cutting paths with navigation. We can use bone reduction under a navigated approach. We can, as I showed you just now, using pterygoid implant surgery, zygomatic implant surgery can be navigated, corticotomy surgery, bone harvesting, cuspid exposures. The next step is really to kind of integrate this into a digital operating room. This is our operating room. We're really the only periodontal specialty practice in all of Illinois that has an office-based surgery center that's accredited through the AAAHC. So we kind of work in like a mini hospital, which I think underscores safety and infection control and standards that you kind of see in a hospital, which, this was done, we did this 5 years ago, and now everybody's talking about safety. But I think these are things that are probably going to be coming, the more complex, we ratchet things up in dentistry, and with the crisis like we have today. This is our anesthesiologist, and we've got our monitors up. And so the next step would really be to have that optical tracker kind of mounted from the ceiling, so that we don't have that cart to deal with. We have our monitors up. We can be looking at the software, and then the optical tracker mounting down on the patient, and who knows, maybe even having intraoral cone beams at some point. I do think that probably haptic technology is part of the future, and I know that Doron and everybody at Navident is working on that. And so what you see here on your right is a prototype of using haptic technology under the umbrella of navigation in Navident. And I'm pretty sure that's not going to cost $200,000. This is the Ryomi system on the left, which I think is relatively obtrusive. But I have to say, if you're a maxillofacial surgeon and you're doing a lot of navigation, or you're doing a lot of zygomatics and so forth, that may make sense. But for most of us worker bees who are in the trenches doing aesthetic cases as periodontists, that's really our wheelhouse. This technology makes a lot of sense for us. So in conclusion, try to change the perception. The computer's got to be a partner during surgery, not an obstacle. And when you're using this technology, you can't get in the way of the optical tracker. The computer's got to be able to see the patient in your handpiece. Now, initially, I was always trying to kind of make the system fit the way I worked, and it doesn't work that way. You have to change workflows, and you have to change the patient positioning so that you fit the system. I do think that trace registration has become a game changer for us. The lack, not needing to use a fiduciary marker any longer has just simplified the workflow, and it has reduced the cost to a degree as well. I can't underscore the fourth point here about being fanatic and scrutinizing accuracy checks at every step along the way. It's the only way to ensure that the next step is correct. Because if the last one was wrong, everything just compounds. Case selection, garbage in, garbage out. If you fail to plan, you're planning to fail. And as Ronald Reagan once said, "Devrier no provrier," which basically means trust but verify. And that's what accuracy checks are all about. So, in my opinion, this is superior technology. It is definitely moving the profession forward. It gives us on-the-spot surgical accuracy and transparency and real-time verification, but it'll never be a substitute for due diligence in planning, surgical execution, or surgical experience, knowledge, or judgment, or the need to really have a team-centered approach to how we take care of our patients. With that, I hope this has been helpful. I want to thank you for your attention. This is our website. You're welcome to email me at any time. My email address is gmandelaris@periodontalmedicine.org. There are documents that will be found here. And I also want to put a shout out to the next group of webinars coming up with Navident with my close friend Sylvia LaRosa, really one of the world experts in this in this field as well. She is tremendous, and her cases are fantastic. You'll get a lot out of listening to her. And then Dr. Nadeau and Villa and Chen, who will also present on Navident. So with that, I appreciate you taking the time to listen. Brad and I are thinking of all of you and all of our friends throughout the world, and hoping that you're staying safe, you're staying vigilant, you're well, and we look forward to seeing you soon, and stay healthy.
Hey, George, one of the questions that we've gotten a couple of times is, how do you complete the bone reduction surgery for a full arch case with navigation? And can you talk a little bit about that?
Can you hear me, Brad? I can't hear you.
You cannot hear me?
Can you try again?
Sure.
Okay. Thank you.
You got me now?
Gotcha.
Okay. So sorry, one of the questions that we've gotten a few times is how and when are you performing the bone reduction for the full arch cases if you're using a navigated surgical technique?
Yeah. So, to be quite honest with you, I haven't done a lot of those. In the case that I showed you with the upper arch immediate all-on-4 that I performed, there really wasn't any bone reduction necessary. In the case that I had done a couple years ago, we basically kind of eyeballed that off of a denture setup. So that would kind of go back to really planning on a case like this. I do think that if you were able to put in mini implants or the mini screws before the surgery occurred, and then have your prosthetically directed, you had your denture kind of set up, and you could kind of visualize exactly where you want to do your bone reduction, you could use the mini screws that were put into the jaw and kind of key off of those. So that's how I would use it.
And so then the other, I think a lot of the questions were just on the workflows and are you able to plan the case in advance? And I think we've sort of addressed that with the mini screw protocol. I know, I'm not sure if you have done this mini screw protocol, but some questions about when can that be done, or how is it invasive? Do you need to do a flap? I don't know if you can address that. So,
there is a level of invasiveness to it, but it really is minimally invasive. It's not something that would require sedation or anything like that. It's something that can be done, I would do it at least a couple of days before the surgery. I would make sure that you had the denture setup, already done. I would then probably put 5 to 6 of the mini screws in strategic positions, kind of like a triangulated plane almost. I would do a little mini flap, make sure that go ahead and put those all the way down, go ahead and put your denture setup in, image the patient, and then, at least give yourself a day or so to really kind of think through things and plan it. And not just to think through it in terms of where am I putting the implants, but think through it in terms of the workflow. Like, what is every step going to look like when you get into the operating room and you're using the technology on the patient? And oftentimes what Brad and I and Alan used to do is we just write up a script. You know, the first thing we're going to do is we're going to drape the patient. We're going to use povidone. We're going to anesthetize. We're going to make a crestal incision. We're then going to do flapper. I mean, every little step along the way, like an airline pilot, that going back to that book, you know, is written out. So it is well thought through. You know, it's well thought through, so that there's no hesitation.
One of the other questions we received was just a practical day-to-day financial question. And, you know, I think if you can speak to, you know, are you able to build this out as a guide? Does it improve surgical speed? Does it improve the amount of redos or the amount of time you have to spend? Or how would this, I guess, how would this technology make you as the clinician more profitable?
You know, I don't know. I don't really look at it that way. We look at it as basically like a case complexity. So the way we do fees in our offices are, you know, based on the complexity of a case. So we bundle things as a professional fee, and then we also have an anesthesia fee. This is just kind of a part of our workflow, and I think that we've, you know, we kind of expect, we have this level of expectation from our practice. I can't tell you that you'll be more profitable using it, but I can tell you that you'll execute better. And as you do more and more of it, it will add a little bit of time on, but you know, the time is really kind of irrelevant compared to the level of accuracy that you can obtain. And so, you know, for us, you know, really where it matters is in the aesthetic zone, because there are no, I mean, any type of do-over in the aesthetic zone is going to be a compromise. And so the more minimally invasive we are, the more we can preserve the pink aesthetics of the case, the more we can really get the implant in a good position to optimize prosthetics, the more critical that is, you know, for me. So, I mean, that's just a part of, you know, with everybody and their mother getting involved in implants today. I mean, you know, if we're going to be doing a case, it's got to be, you know, it's got to be accurate, and that's why we use the technology. So there will be a little bit of a learning curve. I would say if you're scheduling an hour and a half for an implant surgery on number 7, you might schedule 2 hours, but you can't go into the operating room not have already thought about the case. There is going to be a fair amount of due diligence on your part, you know, to think through things and to plan. I don't know that you could charge it out, you know, as insurance. I would assume that you could, you know, if that individual's policy covers a surgical guide.
I think, unless I missed something, we've covered all of the questions. So thank you again to everyone for participating. If I have missed you, you can fling it up on the chat real quickly and we'll try to address it. But otherwise, have a wonderful evening and stay safe.
Thanks, everybody.
Thank you so much. Wonderful presentation as always. And thank you, Brad, for moderating. To all the attendees, you will be receiving within the next day or two an email to the email address that you registered with. And that will include the link to your CE documents and instructions, as well as a recording of this program and a link to future courses that we have. As of today, we actually added another course on May 27th at 1 p.m. Eastern Time. Dr. Luigi Stefanelli will be presenting on the pterygoid implant cases that George showed a video of earlier. So I look forward to seeing you there, and thank you very much. Thank you, doctors.
Thanks.